Hello, everyone. Welcome to our webinar, Myths and Facts about Family Planning for NMOSD and Other Rare Neurological Disorders. My name is Sumaira, Ismi Sumaira, marhaba. I am the founder and executive director of the Sumaira Foundation. I am tuning in live from Riyadh in Saudi Arabia, where I'm attending the INIC 24 conference. This is the first neuro-immunology conference in the Middle East, where there is a big focus on NMOSD and MOGAD, which of course is a great achievement for our community. But just a few housekeeping items before we get started. First, I'd like to introduce you to Sharuk.
Nice having you all here.
Sharuk is a friend of the foundation and works for AstraZeneca, without whom this webinar would not be possible. So this webinar is being recorded and it will be available for replay on TSF's YouTube channel, as well as our global website. Everything that you ask, you will ask in privacy. Your identity will not be disclosed. We understand that family planning can be a sensitive topic. So if there's any question that you have, understand that it will be asked anonymously, and Dr. Shatila, who I will introduce in a second, will be very happy to answer as many questions as possible. To our live audience, this webinar will be conducted in English. However, we have made it so that anyone who needs it to be in Arabic can simply change the settings in their captions on their side and select Arabic. And that is how you will get simultaneous Arabic captions and translations. So without further ado, I don't know if I already said it, but happy NMO Awareness Month. March is NMO Awareness Month. Without further ado, please join me in welcoming our featured expert, Dr. Ahmed Shatila, who is currently based in the United Arab Emirates in Abu Dhabi. The floor is yours.
Well, first of all, thank you very much, Sumaira, for the introduction. I'd like to thank everyone for joining today. Without the support of the people around the world who actually have an interest in diseases that are rare, such as NMO or MOGAD, or even NMS or even MS, none of these events could ever be possible. So first of all, thank you everyone for joining today. And as Sumaira said, NMOSD, the March is the NMOSD Awareness Month. And this is a testament to the foundation and to the work of everybody who's ever had anyone with NMO or loved someone with NMO or has cared for someone with NMO to raise their voice, to speak up, and make sure that their voices and their concerns are heard. So thank you for all the foundations that have made this month possible. So today's lecture, or not even lecture, I don't want to call it a lecture. Today's presentation really, it's brought to you by the Sumaira Foundation by a grant through AstraZeneca, whose support this event could not be possible. So without further ado, I'm Ahmed Shatila. I'm a neurology consultant at Sheikh Shakhbout Medical City. Now, I've been in the United Arab Emirates for about 12 years now. I moved here in October 2012. I came from Detroit, Michigan, where I did my residence. Well, actually, I did my undergraduate, my medical school, my residency, and my fellowship, all at Wayne State University in Detroit, Michigan. If there's any Wayne State University alumni, go Warriors. After that, I then went to Grand Rapids, Michigan, where I worked for 2 years, and then finally Kalamazoo, Michigan, where then after that I came to Abu Dhabi. Now, NMOSD, or just a brief introduction or brief history about myself. I'm a neurologist and I'm a neurophysiologist. I'm board certified in neurophysiologist. So I'm not a neuro-immunologist, but I have an interest in neuroimmunology. And part of the reason why my interest sprouted up is because when I was a first-year medical student, I got diagnosed with MS. It was scary. It was worrisome. I had so many questions at the time. And one of the biggest concerns I had was when I got diagnosed, I had so many questions, but yet I remember so early on when I was sitting with my doctor and my father was with me, will this disease make me disabled? He's like, it could, but it couldn't. Can I die? He says, it may not. Will the treatment work? He says, it might not. So, I left that discussion, or I left that meeting more confused than with questions than answers. I'm like, this doesn't make sense. How's this working? But that's what sparked my interest at that point in MS. And I wanted to do MS. I graduated medical school. I remember my interest in MS really, or my interest in neurology, was during my lumbar puncture. I had a lumbar puncture, and of course I had the horrible headache that some of, up to a third of people with lumbar punctures will get. It's the worst headache you can ever experience. And I'm studying on my back, reading neuroanatomy just up top, and I'm thinking, this sucks, but at the same time, I want to learn more. And that's when I decided I want to be a neurologist. And then I became a neurologist, and we are now in 2005 at the time. And even though MS is not NMO, but there are many similarities. And the similarities are there weren't a lot of diseases for MS in 2005. Well, there were just the interferons, and we had glutathione. And as a result of, I wouldn't say ineffective drugs, they were effective. They were cutting edge at the time. Only 30% effective, but you go to a neurology clinic in 2005, 50% of the patients or people with the disease are in a wheelchair, are using crutches or cane. And that was a very scary thing for me. And after which, I'm like, no, I don't want to do MS. I'm too afraid. I'm going to run away. And I decided I want to be a neurohospitalist. But it wasn't until I finally come to Abu Dhabi in 2012. And in 2012, at that point, I'm like, I don't want to do MS. I'm running away from this, because my denial was so strong, and my anger and my fear was so great that I'm like, I just don't want to do this. I can't take care of you, even though MS is what made me become a neurologist. It was the fear that made me run away. And then I finally saw my first patient in 2012. His name was Amjad. And Amjad comes to me, he's 18 years old, and he's with his father, and he's newly diagnosed. And at that point, it was like deja vu hit me all over again. I saw myself with my father in that interview for the first time, talking to me, and everything his father was asking me, I saw my dad asking my doctor, and everything Amjad was asking me, it was like, it really felt like deja vu. And I'm like, you know what? I want to do this. I want to take care of people with MS. It was always what I wanted to do, but that's what kind of sparked my interest to go back into this field and try to be the best doctor I can. And from that point, MS was, I would say, my bread and butter. That was my main interest. But as you know, most neuro-immunological disorders, they kind of come in the same wastebasket or same wastebasket or same basket. They all come together. They're lumped in. And that comes into our first question. Is MS the same as NMO? They're not. They're two different disorders. MS is not antibody associated. We don't really know why you get MS. We think we know how. It's always changing. We used to say it was a T cell mediated disease. Now we think it's a B cell mediated disease. Now we think it's more of an amalgam of your B cells and your T cells, but we really don't know what causes it. And on the other hand, we know what's driving the disease. We just don't know why it's driving it. We know that people with NMO, they have a positive antibody to aquaporin 4. And aquaporin 4, it's an interesting molecule. It's present all throughout the body, but it's predominantly present in the brain, but specifically in the optic nerves and in the spinal cord. So because there's a lot of aquaporin 4 antibodies, which helps with water regulation, your body attacks those channels, causing water dysregulation, thus causing the cells to die and become dysfunctional. And that's why NMO is predominantly a spinal cord and brain disease. Unlike MS, MS can be any type of symptom. Double vision, blurred vision, loss of vision, weakness, bladder, bowel, sensation, you name it, you can get it. It's kind of like one of those, if you play darts, wherever the dart hits on the dartboard, if each specific portion of the board is a symptom, that's the symptom you're going to get with MS. But with NMO, it's a lot more predominantly focused. Optic nerve, spinal cord, and you do get some other symptoms that aren't rare, but they do happen. The hiccups, the nausea, the vomiting, and the narcolepsy, as well as specific brainstem disorders. Those aren't very common with MS. That's actually a myth. You don't get hiccups with MS. You don't get nausea, vomiting, specifically from MS, unless you have vertigo, and you don't get the narcolepsy. So that's one of the big difference from MS and NMO. Another thing, how long have we known about NMO? NMO has been around since 1894. It used to be called de Vic's disease, named after the French neurologist. Then it became known as optical spinal MS because, again, we used to think it was a demyelinating. We know it's a demyelinating disorder, and we used to think, oh, it's just a spinal cord optic nerve type of MS, which is more severe. We now know, no, it's not. That is a myth, that they are not the same disease. They're not driven by the same factors of the disease. As I told you, NMO is predominantly an antibody-mediated disease. MS, we don't really know what's going on with the MS because it is extremely confusing since 1864 till today. The more we know, the more we realize we don't know. So the brief introduction, I guess, with NMO. Now, I know this presentation is predominantly about NMO and pregnancy, or NMO, pregnancy, and other rare diseases. So I'm going to talk about that, but there's going to be interluded throughout this presentation some other myths and facts. So when pregnancy is important. If people didn't get pregnant, we probably wouldn't have, 8 billion people in this world today? I don't know, 7, 8. And it's amazing. When I was a kid, it used to be 4. So now we're 8. So it's doubled in my lifetime. And I'm not that old. At least that's not what I would hope not to think so. So pregnancy is important. And it's even more important in NMO because women are affected 9 times more than men. And the range of people that are affected can vary. Now, when I was studying, we used to always say NMO, yes, it's a women predominantly disease. And it's an older women, older than 70s women type predominantly disease. But that's a myth. You can actually have people affected with NMO throughout any course in their lifetime. Yes, there may be a higher risk as we get older, but you can have people extremely young. My youngest patient with NMO, she was diagnosed when she was 15. So that's a myth you got to keep in the back of your mind, that NMO is not a disease just of the elderly, and specifically elderly women. Now, when we think about pregnancy, now I'm going to kind of, like I said, go back and forth. This is not a presentation that has slides. I have topics, I have ideas, and my son is interluding in the background. You may see him. Just a little interesting point. I told my son today, why don't you join? You could help boost up the audience. He's like, why would I join? When you go to a concert, do you go live or do you watch it on TV? I'm like, okay, touche. So my son's sitting in the background, the orange shirt, in case you see him, he's watching this live, even though I wanted him to join it. But it's all good, all for awareness. So pregnancy, when we go back to pregnancy, can people or women with NMO get pregnant? And the answer is yes, but with caution. You see, that's going back to another myth now. In MS, the disease actually gets better during pregnancy. We used to think it's kind of protective. During your first trimester, your rates of relapses in MS decrease with every trimester until it's the lowest in the third, and then kind of rebounds after your delivery, and usually it's the highest the first trimester postpartum. In NMO, it's actually relatively stable, the risk, and it's even slightly higher than before pregnancy. And we do know that actually postpartum is the highest rate of relapse in NMO patients or people who have NMO. So the postpartum rate of relapses is actually the highest. And there was one study done where a lot of first-time presentations of NMO was first-time postpartum delivery. So there is an increased risk of that. So keep that in mind. So the answer is, can they get pregnant? Yes, they can get pregnant, but there is a risk of relapse, and that will go into treatment when I talk about some other myths and facts later on. Can you breastfeed? Can women with NMO breastfeed? The answer is yes, you may breastfeed. Breastfeed, while breastfeed doesn't cause relapses, the debate of whether breastfeeding is protective or not is one of those time-old questions that we have been going back and forth on. In MS, sometimes we say it's protective, sometimes we say it's not protective, but no, I'm sorry, sometimes we say it's protective, sometimes we don't know if it's not protective, but at least we know it's safe. In MS, we know that breastfeeding is safe. In NMO, studies have shown the same thing. Breastfeeding is safe. It doesn't increase your risk of relapses. And that being said, breastfeeding is important for the newborn child because, as we know, breastfeeding does not just improve immunity, improves cognition, and improves the overall, bonding with mother and child. So it is an important thing, especially if someone wants to breastfeed. It's not one of those reasons why you would not want to breastfeed if you choose to desire to not to breastfeed. Next thing. So we talked about pregnancy, we talked about breastfeeding. So now we'll go into a little bit. I did allude at the beginning about treatments. Now, when we look at the field of immunology, NMO, when I was in training back in 2005, we didn't have any treatments for NMO. Well, we had treatments, but they were kind of like the old wisdom tale that was passed down from teacher to student and so on and so forth. Like we had the Imurons, we used our CellCept, we used cyclosporin, and these were the treatments that were passed down the generations from the teachers before me to by the teachers before them. But we never had a NMO specific treatment. So back in 2005, the treatments we had treatments for the relapses. We gave steroids, they worked. We gave plasma exchange, which was just right in the beginning showing. There was a study done in Mayo Clinic and when I was in medical school that showed that it was beneficial. So we were using plasma exchange. Rituximab, as simple as it seems right now, was modern, was rocket science, was space age. To use rituximab back in early 2005, it wasn't common at all, and very few people were actually using it. Now it seems like rituximab is one of those drugs that actually treats a lot of disorders, and we're learning a little more and more about it. And then it kind of went on hold up until the past 4 years before we finally started getting our first NMO-specific treatments, whether it was cetralizumab, eculizumab, ravulizumab, or inebilizumab. So within the span of like 200 years, 300 years, we had nothing. And then in the past 5 years, we've had 4 treatments. And that's very promising because if you look at MS for 200 years, we had nothing. And then in the last 10 years, since I've joined or started working in the UAE, we now have more than 20. So that always gives hope for people that there's always newer medications coming, better medications of older formulations that are coming. So the question is, can I get pregnant or continue to be pregnant if I'm on medicine? And the answer I'm going to give you to this is I'm going to give you the scientific answer, but then you got to also use it with a pinch of salt. And the reason why I say pinch of salt is because I'm giving this presentation to the audience around the world. I don't know where home base is. And sometimes, we got to go back to the local rules, the laws and regulations of the country which you live in. But so the scientific answer is, can you get pregnant on rituximab? The answer is yes. Can you breastfeed on rituximab? The answer is yes. The short answer is yes. What do I mean about that? Meaning that you need to, if you're going to breastfeed on rituximab, you should at least wait the first week. Now, why the first week? Because when baby's born, the first week of milk that's made by mama is actually colostrum. It's a very fatty milk that's rich in immunoglobulins. And that's what rituximab is. So you don't want to give all that immunoglobulins from mama to baby. So we usually say, hold off the pump first week, pump and dump, and then breastfeed. So that's the only cautionary tale I would say. And then you got to go back to the local rules and regulations of the country. Can you get pregnant on revilizumab or eculizumab? Again, the guidelines recommend that you should not withhold treatment if you're on these medications to get pregnant. Now, does the label say you should get pregnant or you should continue pregnant? Again, that is country specific. And I would definitely, you would have to ask your doctor wherever you live around the world about that. The other medications, Imuron is safe for pregnancy. You can get pregnant on Imuron. Breastfeeding, it should be considered safe as well. Again, cautionary tale. Inebilizumab, I don't have anybody on inebilizumab. It is not available in the UAE on it, currently inebilizumab. So my experience is somewhat limited, but I would imagine, again, cautionary tale, that it would use the same guidelines as most, what do you call it? Most immunoglobulins or most monoclonal antibodies. And we usually say that monoclonal antibodies don't cross the blood placenta barrier until 6 months. So normally we say the first 6 months are relatively safe. Even if you were to get a monoclonal antibody, scientifically speaking, it shouldn't cross from blood to placenta until after 6 months of being pregnant. Now, does it go into breast milk? Well, it's in the blood, and blood has got immunoglobulins, so it will go into breast milk. The question is, how much will be in the breast milk? I don't know. So I can't comment on that. Cetralizumab, I have very little experience with that, and the label says don't give it, so I will have to respect the label on that. When we go back to other myths, I was talking about pregnancy, I was talking about NMO. Now we talk about diagnosis. How do you diagnose NMO? NMO, I told you, it's an antibody and it's a channelopathy, meaning your body is attacking the water channels, mainly in your spinal cord, mainly in an optic nerve, and sometimes in your brainstem. Now there is a test, it's called the aquaporin 4 monoclonal antibody, or the aquaporin 4 antibody test. It's got almost like a 95% prediction. If you have a positive test with symptoms, it's almost diagnostic. There is a slight margin of error, but it's very low. Now, can you have NMO and have a negative test? You may, and you can. That's actually a whole, now the requirements for having a negative aquaporin 4 test and still having NMO, you need other criteria, meaning that if you had optic neuritis and a positive test, I can diagnose you with NMO. If you have a negative test, I can still diagnose you with NMO spectrum disorder, but now you need transverse myelitis, optic neuritis, or one of the other minor criteria, like I said, narcolepsy, hiccups, intractable nausea, vomiting, or other brainstem symptoms. Is NMO rare? It's extremely rare. Well, not extremely, I guess, but it is rare, a lot more rare than MS. In my clinic, I currently have 400 people with MS. I only have 4 people with NMO. So you're looking at almost a 1 in 100. Different studies around the world have different rates, but we're looking at around 10 per million to maybe more like 19 per million, depending what part of the world you live in. But still, that's a very low risk. Looking at MS is usually 100 per, it's 1 per 1,000. So it's a lot lower than MS. Are they the same disease? Is NMO and MS, well, let me say another way. If you have NMO, will your child have NMO? The answer is no. Just because you have NMO does not mean your child's gonna have NMO. Now it is autoimmune, and some autoimmune disorders do kind of pass down from mother to child, but it's not a one-to-one, meaning it's not like eye color or skin color or, the, I'm blanking on the word, the double chin, but there's a higher risk, but it's not passed down. Just because you have it doesn't mean your child will have it. Is it contagious? No, it's not contagious. If you have it, is it gonna pass down through breast milk? No, it won't pass down to breast milk. Just because you have NMO and you're breastfeeding, you are not going to give it to your child. That's also something important to think about. Uh, there were some questions, some things like, are the treatments support limited? Support NMO, well, actually, support may be limited in the country you live in, but that only raises the need for awareness. You know, there's a saying I learned when I was a resident, only the squeaky wheel gets oil. If you don't raise your voice, if you don't advocate for a change, no one will ever change. And no one will ever, if you don't say, look at me, we need help, no one's going to help you. So if support is limited in your country, that's where it would be important to raise awareness, grassroots movements to show other people that yes, we exist, this need is around. And usually, I do believe people are genuinely good. And with that, I mean, sometimes the only reason why they may not help you is because they just don't know that the need existed. And I like saying that in the United Arab Emirates, just last year, they formed, I don't say finally, there was always support, but there was, for the first time, a national MS society in the UAE. There was always support, but it was intermixed. It was, some places had it, other places didn't. But for the first time in the UAE, United Arab Emirates, we now have a national MS society. And I love to say that, yes, the MS society has many hats, if you want to say. It advocates for educating the public, educating people, advocating for disability rights, research. But what I like to say, it's a symbol of hope. It's a symbol of hope for anybody with MS or who's cared for MS or who knows someone with MS that there is potential for a cure. And this is a platform that voices our concerns to the relevant authorities to say, look at us, we need help. And the help, and that's important. And that's why I believe advocacy and raising awareness, such as the Sumaira foundations or other foundations around the world, are much needed. And you can never have enough. And I'm proud to say I'm the medical advisor of the National MS Society, and I believe in this, and I believe in advocating for people's rights and patient. I don't like saying patients, people who have a chronic illness, because patients are what I see in the hospital. People are what we all are. So let me see. Are there any questions? So, Sumaira, feel free to interrupt me at any point in time, or because I could talk for hours.
Hi.
Hello.
Yes, well, please. That was an excellent presentation, as
Thank you.
expected. Does anybody have any questions for Dr. Shatila? Please don't feel shy. If you want me to ask for you, I'm happy to do that. I just kind of have a general question, if that's okay, Dr. Shatila.
Sure.
I remember, I'm going to age myself a little bit, but I remember when I was learning about pregnancy and all of that back in high school a long, long, long time ago, it was always said that this anytime after 35 would be difficult to conceive, regardless of what, your health situation is. I'm 35 now, and I feel like most of my friends who are my age are just starting to have children now. So is that number still true? Like I hear about people having children in their 40s. So can you maybe speak a little bit on the age factor with having birth?
So yeah, I mean, hello. I think we I think
You
we're
have
breaking up,
MS or
or
NMO?
I kind of got to the point about the age factor and
See
then
you?
everything broke up. So I see you and I hear you, but there was a slight technological, what do you call it? Internet gap. So you were saying age factor and then we kind of broke up, Sumaira.
Yeah, I'm just curious, like, is there still this like age after which you have a child or you try to have a child, it's, not safe anymore? I mean, obviously you shouldn't be doing it when you're 50, but I hear of people leaving their 50s, early 40s. So
Okay.
did you lose me again?
I did, but I think I got, I'm gonna make you repeat it a third time. So
Okay.
I got the gist of it. So
Okay.
can you get pregnant after 35? Definitely you can get pregnant. You can keep getting pregnant until menopause. Now, the thing is, back when I was a student, not that long ago, I would hope, we used to say that it's not that you can't get pregnant, but there are certain disorders that kind of increase as women age. Down syndrome has a higher risk in people who are older and get pregnant, older meaning in the 40s. I mean, actually, kind of increases as you get older, but it seems to be the highest in people after 40, like Down syndrome. Not Down syndrome, yeah, Down syndrome. I don't know why I blanked out. So, yes, you can get pregnant. Certain disorders may be more prevalent as women age. But does that mean you can't get pregnant? No. And technology has gotten so much better over the past. I mean, I was just talking about technology in medicine. In the past 10 years where I trained, we had no treatments. Now we have so many more treatments. And that's not just treatments. We have ways to follow women who are pregnant a lot better now than we did, 20 years ago. I remember when my son was born, it was just a 2D black and white ultrasound. Fast forward to a couple years ago, my third son, now we're doing 3D real life. I mean, and we're not talking the shady 3Ds that you kind of have to close one eye and imagine what the baby looks like. No, they're fascinating images. So technology is improving, and yes, while these images are great, but it's not just all cosmetic. These are great technology to see small birth defects, small any minor abnormalities, and that the baby may be developing. So the short answer to your question is yes, you can get pregnant. The longer intertwined is that you may need to have closer follow-up. Now, when we look at people or women with autoimmune disorders, same thing goes for them. They can get pregnant, most definitely, and I actually encourage my patients to get pregnant. Pregnancy or having an autoimmune disorder is not a reason not to have a child if that's what you wish. Uh, we have we have many medications now on the market that actually are safe during pregnancy, or experience tells us that we can give through pregnancy. We have medications that are safe through breastfeeding. And we're not talking like we've seen it through clinical trials or through expert experience. The first MS medicine that's FDA approved for breastfeeding is Symptom. It's a monoclonal antibody. It's given injection and it's actually safe for breastfeeding. A lot of times, sometimes the doctor may tell you, well, we're not sure, but we think it's safe. No, we know this is safe. And so this is again showing you how the research has gotten better. And what I would probably, I kind of went on a tangent here, but the answer to your question is if someone wants to get pregnant, by all means get pregnant. Living with a chronic illness should not prevent anybody from pursuing their dreams if that's what makes you happy or if that's what you wish.
Okay, I've got another question for you. Just to reinforce to our live audience and those who will be watching this after the fact, can you confirm that NMOSD and MOGAD are not hereditary? So if you get pregnant, being a patient yourself, will you pass the disease on to your offspring?
Is it her? So, okay. Is it hereditary, meaning if I have the disease, my child will have the disease 100%? No, it's not
Yeah.
like that. It's not like that.
Okay, yeah.
So just because I like to say it's more like other conditions such as like, and I use diabetes so often because most people know somebody in the family with diabetes. And I usually,
Mhm.
and it's not type 1, I'm talking about type 2 diabetes. We know that type 2 diabetes, it tends to cluster in families, but just because your dad has diabetes doesn't mean you're going to develop diabetes. There may be a genetic predisposition to it, but that doesn't mean you're going to get it just because your loved one or your parents have it. NMO, MS, or any autoimmune disorder kind of follows that same idea.
Okay, great. And it's so funny because over the years of, you know, advocating for NMO and MOGAD over the last 10 years, whenever I speak to women of childbearing age and those who have children, I always hear that patients, female patients are like, I love to be pregnant because when I'm pregnant, my symptoms go away. So it's almost like a vacation from your disease when you're pregnant.
I hear that all the time, and I never understood that. And the reason why I say that because I'm so fascinated by, you know, when the women in my clinic get pregnant, usually they're coming in, you know, you've got the big belly of, you know, a 7 month, 8 month pregnancy. And I'm like, you're not unsteady. You had a hard time walking before you were pregnant. You had the wide legs, you were wobbly. Like, no, I feel great. I'm like actually more energetic. I can walk faster. And I'm so amazed by that because not only are they stable, they're actually improved to the point that a lot of their symptoms pre-pregnancy seem to go away. It's like I've always found that fascinating, and in my mind I'm like, if you had a hard time walking without the baby in your stomach and the 10 pounds of water, I would imagine it would be harder as a guy with that extra adage of weight. But it's so amazing that they do so much better being pregnant than before pregnancy.
Absolutely. I am going to actually, we have a live question, and she's the one from Michigan. So if it's okay with you, Kayla, why don't you go ahead and introduce yourself? I'm sure Dr. Shatila has a lot to talk about with you about Michigan, but go ahead and ask him your question live.
You meet oh,
Okay. Can you hear me okay?
oh yeah,
We
I
sure
hear
can.
you.
Hi, Kayla.
Hello. So I'm a Michigander. It's nice to see someone else in Michigan
Oh yeah.
that knows so much about NMO and NMOSD. So I really appreciate you coming on today and sharing with us your knowledge. So I'm a 36-year-old female and I'm numb from the waist down. I did end up getting some of my feeling back in my torso after treatment, but I went 7 months with no diagnosis. So I kept relapsing over and over. So I utilize electric wheelchair, but I try using a walker as much as possible. My question for you is, do you think that for any female being numb, you know, from the waist on down, that could cause complications giving birth or any kind of defects?
Okay. It's a great question, Kayla. And first of all, I don't want to say I'm sorry that you're numb from the waist down because I know it's an unfortunate, but I feel for you. I feel because I use a wheelchair, and I know that most people, I'm not sorry for anything I have. So that's why I was like, I don't want to say sorry as a form of pity. I want to empathize with you, but I don't want to feel sorry for you because I know that, and I hope that like you, like any people with a chronic illness, you don't want pity, you want strength or you want empathy. So, so your question actually is it's a remarkable question, and I hear this a lot. If I have weakness from the waist down, can I have a normal vaginal delivery, or do I need a C-section? And the answer is it depends. What does that mean? So, first of all, in order to deliver vaginally, you have to have strong abdominal muscles to push the baby out. Now, if your abdominal muscles are weak, you're going to have a hard time pushing the baby out when it's time for childbirth. And for people who have a severe abdominal weakness, C-section may be more of a preferred way. Now, that being said, now you may say, well, okay, I'm not completely paralyzed, but I'm weak. So the thing with that would be being weak, but are you strong enough to push the baby out on your own? And that depends. Some people they have weakness in the lower extremity, but they still have a decent amount of abdominal strength where they can have a normal vaginal delivery. Now, will being weak in and of itself make you have a more undesirable outcome or a bad outcome on your baby? The short answer is no. I don't know of any evidence that just because you're paralyzed and the waist down, the risks of the baby would be higher, which risk to the baby would be higher. You would definitely need to follow with an MFM, a maternal fetal medicine doctor who specializes in high risk complications. But I hope that kind of helps. And like I told you, I want to empathize with you, but I hope one of the most liberating moments in my life is when I actually used a wheelchair because it gave me the strength for almost 2 decades. I was struggling and suffering to walk, and I fell and I tore some ligaments and I had so many injuries from falling, but I was in denial. For me, using the wheelchair when I first used it, first cane and then wheelchair, I actually thought it was liberating. And I I'm in a wheelchair. It is what it is. I don't feel bad for myself. I don't want anyone to feel bad for me. So that's why I said, I don't feel sorry for you. I empathize with you. And I hope that came across.
Oh, absolutely. Thank you so much for sharing with me. And, I can relate to you as well, being in a wheelchair. And I fell a lot. I quickly went from a cane to needing a walker to I need an electric wheelchair. And now I'm able to utilize my walker more than I was able to a year ago. So work in progress always. But thank you so much for going in depth with my question. I appreciate that. And I know other people who will listen to this will find that very good.
You're welcome.
Okay, we have another question. I know she's a shy one, so I will ask on her behalf. I had 2 children before diagnosis. I did not feel contractions or pain until fully dilated. Too late for an epidural. Could that have been due to NMO going undetected?
That's an excellent question. I mean, so you had 2 children. So the question, wait, let me see. Let me read that question again, but more slowly.
Yeah.
I had 2 children before diagnosis. So the thing about NMO, the spinal cord disease in NMO, they're not mild. They're usually pretty devastating. I mean, it's unlike MS, you can have a mild spinal cord lesion that gives you some mild. NMO is glaring in your face, severe symptoms. I mean, we're not talking blurry vision, we're talking blindness. We're not, you may be weak, but you're more likely to be paralyzed. That's how NMO kind of shows its face for the first time. So the odds are, could it have been an NMO due to a very early on or mild NMO? It's possible, but NMO, you know, from my experience, it's not a mild disease. So maybe you're just one of those women that are lucky to not have a lot of pain. I mean, you hear about it. You know, they don't even know that my wife had my third son with no pain meds, so not at all. You know, the first son, she had an epidural by baby number 3, no pain meds. So, different people, something, I guess you just had you were a really lucky lady. That's how I would say it.
That's funny. She says she'll take her luck. I have another question. It's not necessarily about like directly related to family planning, but women's health. And while we're on the topic, can you speak to about menopause a bit? Like, is it different patients who have NMOSD and MOGAD? Should we expect it to come earlier? Do the medications affect us? I think anything different or what we should expect with menopause would be really insightful.
That's an excellent question, Sumaira. Thank you. So if we look at menopause, I mean, as we know, the symptoms of menopause in women is really related to the lack of estrogen, the failure of what we call the hypothalamus, pituitary connection to the ovaries. There is that two-way street, if you want to call it. Your brain is talking to your ovaries are talking to your brain, and they're each sending each other signals, one through estrogen, progesterone through your ovaries, one through hormones from your hypothalamus or pituitary. So when there's a disconnection in that pathway or a telephone pole, you get menopause, and you get the hot flashes, you get the either spotting of menses or no menses. And that's one thing, everyone always thinks menopause means I don't have a period anymore. No, you could have irregular spotting and start or being premenopausal or actually entering menopause. Can that affect your NMO? Well, before I get to that, can your medicines affect menopause? So now, the newer medications, which I call the monoclonal antibodies, they do not affect a woman's ability to have a month period and do not affect the hormone cycle that normally happens from month to month. The older medicines, that's where you got to be a little bit more careful. Some medicines can. We know that cyclophosphamide can affect your monthly cycle. It can actually cause sterility. So you got to use that. Some of the, with MS, mitoxantrone can also, back then can also severely affect your ability to have your fertility. So some of the older medicines may affect menopause. Some of the newer medications don't. Now, that being said, let's say you weren't on the older medicines, you're on the newer generation of medicines, and now you're entering medicine or menopause. Could that lack of hormones, could that lack of hormones in your body increase your risk? In a way, there may be an increased risk of developing a relapse once the hormones fluctuate, as we know that we see that. The rate of relapses in pregnant females is slightly higher than non-pregnant females. The rate of relapses postpartum is definitely higher after pregnancy. So, the only thing is different is the hormone fluctuation. So if you start losing that hormone cycle, you could potentially be at an increased risk. So the answer is possibly, but as one thing I always like to say, people are very different, and the human body loves to show you that you cannot put everybody into the same algorithm.
Truly. All right, to our live audience, we have time for one more question. So if you'd like to enter it in the chat or use the Q&A function, now would be the time. But until we wait for another question, if we get another one, I will tell you, I mean, I'm an open book about it, so I have no problem talking about it. I was put on cyclophosphamide after failing rituximab 3 times. I'm a seronegative patient. This was early on in my illness, so almost 10 years ago. And at that time, we didn't have the FDA-approved therapies, the newer medications. We were very much resorting to, you know, the gold standard at the time was rituximab, and then there was Cellcept and azathioprine, Imuran, you know, all those drugs. But I had literally failed everything. And so my doctors, you know, they were so worried. And as a last resort, they put me on cyclophosphamide. I was 25 years old. And in addition to all the horrific side effects that a drug like that can have, I was also pushed into perimenopause?
Premenopausal or early?
Early menopause, yeah.
Early
I
menopause.
entered menopause for 6 months, and it was crazy because now I was dealing with NMO, newly diagnosed with NMO, failing every therapy, but also now going through menopause at 25, 26 years old.
Oh,
And,
yeah.
you know, yikes. In the beginning,
Yeah.
I was like, yes, I don't have to have a period. But then I was like, oh gosh, menopause really sucks, you know?
Oh, yeah. I
Yeah.
can imagine.
It was not fun. And, you know, hot flashes, mood changes, everything was a mess. My FSH levels were through the roof, and it was not a nice time. But eventually it went away, and I went back to business as usual. And now I always ask myself, like, is my menopause the real menopause that I'm going to get at the age that I'm supposed to get it at? Is it going to be different than regular menopause because I've already had it before? Hopefully they'll go easier on me next time. I don't know.
Yes. I don't know. It's a good question. I guess you have experience now. You had the unfortunate side effect of dealing with it at such a young age. So you'll be like, okay, I've been down this road before. I didn't like it
Yes,
first time. Well, you know, I'm not gonna like it again, but I'm ready for it.
exactly. Anyway, Dr. Shatila, this was incredible, super informative. You know, we understand that it's a sensitive topic for many people, whether you're from, you know, the Middle East or not. Pregnancy, family planning, menopause, women's health, these are things that are, you know, not easy to talk about. So I'm glad that we were able to have such a candid conversation. I'm sure for our audience who will watch this after the fact will take away many pearls of wisdom for this. So we're so grateful. And to our audience who is watching this either live or after the fact, as Dr. Shatila said, you should not let your autoimmune disease stop you from having or trying to have children. There's so many myths that we were able to debunk today. And if pregnancy is something you wish for and that you dream for, of course, talk to your doctor, but we encourage it and hope that you feel more comfortable pursuing that path after watching this webinar. Dr. Shatila, any last words for our audience?
I would just tell you that you guys are way braver than what you think you are, and you're a role model. I mean, people who live with disability of any type, both hidden and non-hidden, you're a role model for everyone else and around us. And keep doing what you do. Don't be afraid to show that you have weakness. Don't hide behind it. And you know what? Live your life. I think that's the most important thing.
So wonderful. You're also very inspiring. So thank you so much for your time, for your expertise, and thank you to everyone who joined, and of course who will be watching this hopefully for many years to come. Happy NMO Awareness Month once again, and we will see you in a couple of weeks at our Danish webinar. Thank you, Dr. Shatila. I hope to meet you in person soon.
Thank you so much for the invitation. Thank you everyone for listening to me today. Thank you, Sumaira, for the invitation, and AstraZeneca once again for sponsoring this. So, as we say in Arabic, ila liqa. Until next time.
Perfect. See you.
Bye bye.